All right, so the key concept here is that the cardiac cycle describes the mechanical events associated with blood flow to the heart. And the cardiac cycle is essentially just the filling and the emptying or ejecting of blood from the heart. So that cycle of filling up and ejecting out and filling up and ejecting out. There's a little bit in your notes that says that the ventricles, in order to eject blood, must achieve pressure that's greater than the vessel in front of it for ejection. So if we're talking about, and actually before I get there, make sure you know these terms. Systole refers to the contraction phase of the cardiac cycle, while diastole is the relaxation phase. So again, it's just the relaxing and filling up of the heart, and then the contraction and ejecting the blood from the heart. And so, again, the notes say that the ventricles must achieve pressure greater than the vessel in front of it for ejection. So if we're talking about the right ventricle, that ventricle has to have a greater pressure than the pulmonary trunk in front of it in order to force that semilunar valve open and eject the blood out. Same thing for the left side. The left ventricle has to have a pressure that's greater than the aorta in order to open up the aortic semilunar valve and eject that blood out. And the way we do that, there is a term, it's called the isovolumetric contraction phase. So there is a split second in the cardiac cycle where all four valves are closed. The tricuspid, the bicuspid, and the two semilunar valves are closed. So this isometric, and I'll circle it better so you can see it better. This isovolumetric contraction phase. It is a split second. During this time, all valves are closed. And the ventricles contract to build up that pressure and force the SL for semilunar valves open. So there's a small time within the cardiac cycle where all valves are closed, the ventricles continue to contract, and that's going to allow it to build up enough pressure so it does have a pressure greater than the pulmonary trunk and greater than the aorta, so those valves can open and the blood can be ejected. Any questions about that? Okay. And did everybody have that written down?
No.
Oh, go ahead.
You said that SL is semilunar?
Semilunar valves, yeah. So if we're talking about systole and diastole, so the contraction phase and the relaxation phase, what layer of the heart wall are we referring to? Not the pericardium. The myocardium. Only muscle has the ability to contract and relax. Connective tissue does not have the ability to contract. Epithelial tissue does not have the ability to contract. So when we're talking about systole and diastole, we're talking about the muscular part of the heart, so the myocardium. Oh, there's that. But it's the myocardium. Because that's the only one that has cardiac muscle. Okay. So we talked yesterday about the sequence of excitation, or on Monday, the SA node to the AV node through the bundle and the branches, and then to the Purkinje fibers. So what we're going to talk about here is the filling up of the ventricles. So 80% of the filling up of our ventricles is passive. So what that means is the blood from the atria just fall into the ventricles. 80% of that is just gravity doing its job, and the blood just falls from the atria down into the ventricles. That's 80% of our ventricular filling. The other 20% is through atrial systole. So when the SA node sends its impulses and excites the top part of the heart, then the atria can contract. And why the atria need to contract is to push the remaining 20% of that blood down into the ventricles. So most of our filling is done by just gravity, but that other 20% is through the SA node and atrial contraction. So does anybody remember what the ECG tracing is called when we have, when the SA node isn't working and we have a missing P wave? Junctional rhythm. So when that happens, we go from, go back. We go from SA node to the AV node to the AV bundle to the branches and then to the Purkinje fibers. So if the SA node is not working, then we don't get the excitement of the atria, and the atria don't contract. Okay, but we'll get enough filling of the ventricles. We'll get 80%. But we're not going to get that last 20% if somebody has a junctional rhythm, if someone doesn't have the SA node working, because the atria don't get excited, they don't contract, okay? And so we don't get that last 20% of that push down into the ventricles. It's enough to get them going, but they are missing 20% ejection from the heart because they're missing that last bit of contraction to push the rest of that blood down. Okay, does that make sense? Okay. So there could be a question where I ask you, if the SA node is non-functional, how much ventricular filling are you going to get? You're only going to get 80% because you're not going to get that last 20% from atrial systole or atrial contraction. Okay. We're going to learn lots of acronyms today, one of them being EDV. EDV stands for the end diastolic volume. So it's the ending volume after diastole. So after we're done relaxing and the ventricles have filled up, what is the maximum filling that we have of those ventricles? What's the volume that we have to be able to eject out of the heart when it's time for systole? That's our end diastolic volume. How much have we filled up those ventricles? Okay, so the volume of blood in ventricles right before we eject, or right before ventricular systole. So any questions about that volume? So it's just, what are we starting off with? What is the volume of blood in the ventricles that we have to be able to eject? Okay, so when we have a blood pressure reading, 120/80 is our average blood pressure reading. The top measurement is the systolic pressure. This is how much pressure blood exerts against the arterial wall, so like the aorta, when the ventricles contract. So when the ventricles contract and you eject that blood, what is the pressure that the vessels are feeling? Okay, that's about 120. So during that time, when the ventricles are in systole and we're ejecting blood, which valves do you think are closed? Do you think it's the tricuspid and bicuspid, or do you think it's the semilunar valves that are closed during systole? It should be the bicuspid and tricuspid. So these valves, during systolic pressure, when we're ejecting blood out of the heart, the valves that are closed are the AV valves, the atrioventricular valves, which are the bicuspid and the tricuspid. Or I'll say tricuspid and bicuspid, so I say it in order. And so the valves that are going to be open are these semilunar valves. Those are the valves that need to be open for ejection. And then remember that these semilunar valves, they open when capital P for pressure, when pressure in the ventricles is greater than pressure in the arteries, whether we're talking about the pulmonary trunk or the aorta. So when we do take blood pressure, do you think we're taking blood pressure from our pulmonary circulation or our systemic circulation? Systemic, yeah. So when you take a blood pressure cuff, they put it over your arm or your wrist or your ankle, wherever they're taking it from. That's systemic circulation. It's coming from the left side of the heart. Okay, and which side of the heart is thicker, left or right? The left, right? The left ventricle is thicker because it has to pump the blood a farther distance. Your pulmonary blood pressure would be much lower because the ventricles are much thinner and don't pump out as forcefully. So we don't ever take pulmonary blood pressure. We always take systemic blood pressure. Okay, questions? The bottom reading on our blood pressure is going to be the diastolic pressure. This is how much pressure blood exerts against the arteries when the ventricles are relaxed. Okay. That's our relaxation pressure. And so there is another volume that you have to know. So after we've ejected blood from the heart, okay, out of the ventricles to the body or to the lungs, there's always going to be a little bit of blood left over. We can never fully eject all of the blood that's in the ventricles out. There's always going to be some left over. That leftover is called the end systolic volume. So this is the blood that's left remaining in the ventricles. It's like the ketchup that's left at the bottom of the bottle. You can never get the whole ketchup bottle empty. You can never get conditioner or lotion. None of those things you're ever going to fully empty. There's always going to be some that's stuck to the walls at the bottom, right? That's what's left over here. That is your end systolic volume. So it's like the end of a ketchup bottle. Doesn't matter how forcefully you push on the end of it, it's not ever going to empty. Though we try, or at least I try to get every little bit out, but you can never fully empty it. Huh? Cut it open? Okay, questions about the end systolic volume. So your end diastolic volume is what we start off with. How much blood do we have to eject? And then the end systolic volume is how much blood is left over. So what if we had hardened valve stenosis where the opening is narrowed? What do you think is going to happen to that ESV or that end systolic volume? Do you think there's going to be more left over or less left over?
More left over.
There'll be more left over. The reason why is if we have hardened valves where the opening to those semilunar valves is now more narrow, it's going to be so much harder to get that blood past it. So we're not going to be able to get as much past. And if you remember, those stenotic valves, they don't close properly either. So there may be some blood that goes back down through those semilunar valves and back into the ventricles. So what you're going to end up with is a larger end systolic volume. You're going to have more left over because the opening is so narrow that you can't get as much out, and the valve doesn't close properly, so there is going to be some backflow back into those ventricles. So you're going to be left over with more. So with stenosis, it's harder to get blood out. Past the valves. And I'll say the valves instead of they. And the valves may not seal properly. So for both of those reasons, you're going to be left over with the larger volume. And then you can remind yourself that stenosis means that it's going to be a more narrow opening. Okay, any questions about that? Okay. Anybody still writing this? Okay, I see people writing. Oh, wait a second. Everyone good here? So some cardiac cycle clarifications. In common medical work, systolic and diastolic, when we were talking about those terms, we mean the ventricles. We're talking about ventricular systole and ventricular diastole. Now there is atrial systole. We just talked about how the atria push or contract the remaining blood down into the ventricles. If I'm ever talking about that, I will specifically say atrial systole. So I will refer to it as specifically atrial systole or diastole. But if you ever hear those terms alone, just systole and diastole, we're talking about the ventricles. Okay, we're mostly going to be talking about the ventricles. And then, like I mentioned already before, that our right ventricle has thin walls because they're only pumping to the lungs. But they're going to have the same volume as the left ventricle. So even though the right ventricle is thinner and it has less force, it doesn't matter. They're both going to have the same volume of blood. Okay, we're filling both sides of the heart the same. It's just one side pushes out more forcefully than the other. So our pulmonary blood pressure is going to be a lot lower because our right ventricle is a lot thinner versus our systemic, which is what we usually measure, is going to be a higher pressure, 120/80. Any questions about that? Yeah. Repeat what? Oh, so the pulmonary pressure is going to be lower because the right ventricle has thinner walls. So it can't pump as forcefully. And it doesn't need to because the lungs are such a short distance that it doesn't need to pump with much force. But we don't measure pulmonary blood pressure. We measure systemic blood pressure. It would be hard to get in there to measure pulmonary blood pressure. Good, Isaac? All right, so heart sounds, we already talked about these. Sound occur when the flow of fluid is interrupted. So it's not the actual snapping shut of the valves. It's when the blood hits up against it, when blood flow has stopped. So the lub is the AV valves closing, stopping blood flow. Scared when a dean calls me. Okay, so again, lub is the AV valves closing and blood flow is interrupted. The dub is when the semilunar valves close and blood is interrupted. And then when the semilunar valves close after ejection, that's when we're in diastole. So we've just ejected blood, the semilunar valves close, and now we're going to relax. So there is a way to listen for all 4 valves. So when you go to the doctor's office and they feel for your heartbeat and they're oscillating around your back, they're listening to all 4 valve sounds. I couldn't do it, but your doctors know how to do it. Okay. So the reason why you can hear all 4 valve sounds is because the bicuspid actually closes before the tricuspid. And the aortic semilunar valve closes before the pulmonary. So they're all closing at separate times. So your physician can hear for all 4 individual valve sounds. And so they can do it on the front or the back, but they oscillate around in order to fill for all of those sounds. I won't test you on exactly in which intercostal spaces you could hear them in. Just know that you can hear for all 4 of those valve sounds. So it's possible to hear all 4 valves close. And I think your lecture note tells you the order in which they close, like bicuspid, then tricuspid, the aortic, the pulmonary. Okay. Anybody still need this up? Go ahead.
I was just like thinking about the video animation of the heart that you saw like a couple different videos that you showed us, and I didn't know that the bicuspid closes before.
It's milliseconds. It's like it's so fast that, yeah. And so your doctor, because you can hear for all 4 valve sounds, they can hear for valve irregularities and know which valve is experiencing the murmur. Okay. So some other abbreviations or terms you should know. So stroke volume is the amount of blood that's pumped out each time that the ventricles go into systole. So how much blood are we ejecting? Your heart rate is how fast is it working? How many beats are we getting per minute? How many contractions are we getting per minute? And so you should know how to calculate something called cardiac output. So stroke volume tells you how much is being ejected. The heart rate is telling you how fast the heart is beating. But putting it together, cardiac output tells you the timing and the volume. So it's your heart rate is about 75 beats per minute. Your stroke volume is about 70 milliliters per beat. By multiplying those together, it's about 5,000 milliliters per minute. The exact is 5,250, but I'm okay with you rounding down to 500. And 500 milliliters is the same thing as 5 liters. Yeah?
So usually the 70 milliliters per beat is going to be given, right? And so the only variable would be the 75 beats per minute, or?
All right, one of those things could be missing,
Okay.
and you'd have to be able to fill in the other. And so the way that the units work, heart rate is beats per minute, stroke volume is milliliters per beat, and if you remember from elementary school, you can cross-cancel things out, and then you're left with milliliters per minute, which is the unit for cardiac output. So yeah, on an exam, I would have one of those variables missing, and you could input what the missing one is. If that were the case, then if you needed a calculator, I would give you a calculator, but most likely it's going to be these values, the average values, and these are the values at rest. Okay, so make sure you know these are our values at rest. Yeah.
So stroke volume is how much blood is being injected,
Yes.
and the heart rate is how fast it's contracting.
Mm-hmm.
So the cardiac output is both of those together.
Yes, the timing and the volume.
Thank you.
Mm-hmm. So questions about cardiac output? Okay. So again, that volume, that 5 liters per minute, that's at rest. But your heart can pump more than 5 liters per minute if your stroke volume increases or your heart rate increases. So these two things, you're multiplying these things together. So if you increase either one of these, it's going to increase cardiac output, no matter which one that you increase. Or if you increase both, of course, it's going to increase cardiac output. So you can increase that cardiac output by either increasing the amount of volume that you're pushing out or by increasing your heart rate. Either one of those are going to increase your cardiac output. All right, your cardiac output is just telling you how hard is the heart working. And you can actually have a cardiac output of up to 25 liters per minute during exercise. This is called, this difference between 5 and 25, this is called your cardiac reserve. And that's a backwards C. I don't know why I was doing that. This is called your cardiac reserve. And then if you were to have heart damage, let's say you have a heart attack, you would lose that cardiac reserve, or at least partial of it. Again, remember to write down that this is your cardiac output at rest. So ways that we can increase our stroke volume or our heart rate in order to increase cardiac output. So if you are frightened or anxious, or you experience a drop in blood pressure, any one of these things are going to turn on your sympathetic nervous system. It's going to turn on your fight or flight. Okay? And if we remember from when we talked about last time, norepinephrine and epinephrine, your catecholamines, are released at the AV node, SA node, and at the ventricles. And at the ventricles, they're specifically controlling the myocardium. So when the norepinephrine and epinephrine are released at the SA node and the AV node, that is for timing. Because remember, SA node and AV node, those are pacemaker cells. So those are for the timing of the heart. So when epinephrine and norepinephrine are released at the SA node and the AV node, it makes those pacemaker cells work faster. So that's going to increase heart rate, okay? Increasing the timing of those cells. And so that'll increase heart rate during your fight or flight. And if you increase heart rate, you're going to increase cardiac output. Ways to increase stroke volume, which is the amount of blood that's being ejected, is that if you are exercising, okay, so you're exercising, your blood's pumping more, because when you exercise, you wouldn't remember this because I would tell you about it, we didn't learn it yet. When you exercise, so even me just walking, so if I were to walk up those stairs, what's going to happen is that my skeletal muscles around my legs are going to contract and push on my veins, and it's going to cause more blood to return back to my heart. Okay, same thing with my arms. So I'm pumping my arms, that skeletal muscle is pushing up against my veins and pushing more of that blood back to my heart. Okay, so by exercising, you increase what's called venous return. That's the amount of blood that's returned to the heart through the veins. So my superior and inferior vena cava are going to be receiving more blood than normal when I exercise. Okay, because my skeletal muscles are basically squeezing my veins and pushing the blood forward, putting more blood back into my heart. So by increasing my venous return, I increase that end diastolic volume. Remember I said the end diastolic volume is the amount of blood that you start off with in your ventricles before you eject it. So if I'm exercising and my skeletal muscles are pushing against my veins and I'm returning more blood to my heart, my ventricles can fill up even more. So that means I'm going to increase my stroke volume. I'll be able to eject more blood during exercising, which is going to increase my cardiac output. Okay. Does that make sense? Okay. And then also during fight or flight, we already talked about how epinephrine being released at the SA node and the AV node increases the timing and speeds up the heart. But also during that time, you see epinephrine here. It's also going to release epinephrine at the ventricles, which is going to increase contractility. So what that means is it's going to make the ventricles push out that blood even more forcefully. Okay? So by putting epinephrine on the ventricles, it makes them contract more forcefully, a more stronger contraction, which is going to decrease the amount of blood left over. So remember we talked about the end systolic volume and the amount of blood that's left over in the ventricles. That's going to decrease because now we're pushing out that blood more forcefully, so there's less left over. Hey, it's like if my 10-year-old were trying to push up against the ketchup bottle she could get out a whole lot less than I could if I were to bang on it because I'm stronger. Okay? So the more forcefully that you contract, the less blood that's left in the ventricles. Okay? So by doing that during fight or flight, you increase contractility, you have less of an ESV, you have less blood left over. So if you have less blood left over, that means that you ejected more blood than you normally would, which means that you would increase your cardiac output. Now, am I going to have you recreate this entire diagram? No, but you should understand the pathway of how we can increase cardiac output by increasing either stroke volume or heart rate. So any questions on this diagram before I move on? Yeah, Susie.
So stroke volume will only increase when the epinephrine is on the ventricle?
Yeah, if we're talking about epinephrine, norepinephrine only, the only influence on contractility is going to be at the ventricles, yeah. Because again, the epinephrine and norepinephrine release at the AV and SA node, that's only for the pacemaker cells. So that only is going to determine how fast the heart's working. So it's going to speed it up. Any other questions? Okay. So your stroke volume is essentially your EDV minus your ESV. So how much you start off with minus how much is left over, that's how much was ejected. Okay, that's your stroke volume. Your EDV is also referred to as something called your preload. They're not exactly the same thing. Preload is how much your cardiac muscle cells stretch to allow for contraction, but that's not something that can necessarily be measured. And so we actually equate it to your EDV, which is your volume that you start off with. And so this EDV or preload, and I believe this says it in your notes, it's a major intrinsic regulator of the heart. And what intrinsic means, in reference to the heart specifically, it has the ability to control or influence cardiac output or heart activity on its own. So if something is an intrinsic regulator, or if you use the word intrinsic, it means that it has no external control. So there's nothing on the outside telling the heart how to work. Not in this instance. Unless we're in our fight or flight mode, then we have some outside influence to tell our heart to speed up. And make sure that you do memorize these equations. The cardiac output is stroke volume times heart rate, and that we can calculate the stroke volume by taking our end diastolic volume, which is the volume of blood we start off with, subtract how much is left over. That's our stroke volume. That's how much has been ejected. So I'm going to show you how this is an intrinsic regulator, how our preload or EDV is an intrinsic regulator. Everyone have that written down? Okay. For those of you who have printed out the slides, just go ahead like a few slides. I'm going to go here and I'm going to go back. Okay. So an increase in EDV means an increase in preload. And preload, what that is that the more that we fill up our ventricles, the more our myocardial cells will stretch. The stretching causes the myocardial cells to take in more calcium. And the more calcium that we have available, the harder the heart can contract. Okay? That's just how it is. More calcium means a more forceful contraction. Which is why if you have too much calcium, it can cause heart arrhythmias. Okay? Because then your heart will end up overworking too hard. And we'll talk about that a little bit later. So by increasing the amount of blood that you start off with, so your EDV is how much the ventricles have filled. Just how much volume in ventricles after diastole. So the more that we fill up the ventricles, the more those cells stretch, the more that they can bring in calcium, and the more that they can contract. So there's a saying for the heart is that if you fill me up, I pump harder. So the more preload that you have, the more ejection that you can have. So remember we said that when we're exercising, that causes our skeletal muscles to squeeze on our veins, and that returns more blood to the heart. So if we increase venous return, that's going to lead to an increase in end diastolic volume. So we have more volume in our ventricles, which is going to also lead to an increase in stroke volume. If we start off with a larger volume in our ventricles, that means we can eject more blood than normal, so our stroke volume will increase. And if you increase stroke volume or heart rate, that's also going to increase cardiac output. I guess I should do this, but I don't like arrows going in opposite directions. So an increase in venous return means an increase in the end diastolic volume, which means an increase in stroke volume, which means an increase in cardiac output. So the heart is intrinsic in that it can control how hard it contracts by how much it gets filled up. Okay? The less that you fill up the ventricles, the less forceful the contractions. The more you fill up the ventricles, the more forceful the contraction. And that happens all on its own. It doesn't need any other part of the body. It doesn't need hormones or the brain to tell it to do that. It does that on its own. That's how it naturally works. Yeah, Savannah.
What is the ventricular stretch again?
So whenever you fill up the ventricles, that can cause the cells to stretch more. And when the cells stretch more, that allows more calcium to come in. So the less that you fill up the ventricles, the less they stretch. The more you fill up the ventricles, the more they stretch.
Does it play a role in that still?
Yeah. So the more EDV you have, the more myocardial cell stretch you get, which means they can take in more calcium, which means they can contract more forcefully. So questions about that? Okay. So ways that we can increase venous return so that we can increase EDV and increase stroke volume and increase cardiac output. One way is through exercise. So again, your skeletal muscle will squeeze your veins, which is going to force the blood forward, which means that you're going to return more of that blood to your heart while you exercise. Another way is by elevating the legs above the level of the heart. So if you elevate your legs above the level of the heart, then gravity is going to work faster to get that blood back to your heart. So this is what we do when somebody passes out. You elevate your legs so that gravity can do its job, and we can return more of that blood back to the heart so they can pump it out faster, get more oxygen to the brain, and hopefully that they can wake up. So this is a way to help someone come to when they have passed out. Everyone okay with that concept? And then the last way we'll talk about is through an IV. All right, so if we hook up someone with an IV, they're getting more fluids. What you're doing is you are increasing their blood volume. So if you're increasing the volume of blood in general all over the body, you're going to be increasing the amount of blood that's returning to the heart. So we can increase venous return by exercising, by elevating the legs above the level of the heart, and by increasing blood volume through an IV. Questions about that? Okay. So we just covered preload and factors that affect your end diastolic volume, which is the ways that we can increase our venous return. Now we're going to talk about ways to affect our ESV, which is the amount of blood left over. So with our sympathetic nervous system, when that's activated and our epinephrine and norepinephrine are being released onto the ventricles to increase contractility, and you see that here. Remember, if it's the catecholamines that are released at the SA node and the AV node, that's just for timing. That's just for the pacemaker cells. That's just to increase the speed of the heart. When it's attached down here at the ventricles, at the myocardium, that's going to cause an increase in contractility. So it's going to cause the heart to beat more forcefully. So if we increase contractility, what do you think that does to your ESV, or the amount of blood that's left over? Is it going to increase or decrease? What was it? Decrease, yeah. So if we're pumping out that blood more forcefully, then we're going to be able to get a whole lot of more blood out, and so you'll have less left over. So less blood left over after ejection. Okay. Before we go to the next part, though, I want to remind everyone, what is the name of the receptors that are catecholamines, epinephrine and norepinephrine, or adrenaline and noradrenaline? What are the names of the receptors they bind to? Starts with an A, from B32. The receptor. They're called adrenergic. So know that your epinephrine and norepinephrine, which are your catecholamines, and I think this is written in your notes. They bind to specifically beta 1 adrenergic receptors. Do you remember adrenergic for epinephrine, norepinephrine, and cholinergic for acetylcholine? You should have learned about those receptors in B32. But this is going to come into play when we talk about beta blockers in a few slides. Okay. So if we decrease ESV, if we decrease the ESV, we decrease the amount of blood left over. What does that do to our stroke volume? Does that increase it or decrease it? So stroke volume. So stroke volume is the amount of blood that we eject. So if there's less blood left over, does that mean we have more or less stroke volume? More, because we're ejecting more. If there's less left over, we've ejected more out of the heart. So our stroke volume has increased. So we can do that with math. I know everyone loves math.
Yes.
So stroke volume is equal to EDV, the amount of blood or the volume that we start off with before ejection, minus ESV, the amount of blood left over. So normally, our EDV is around 120 milliliters per beat. And our ESV is normally about 50 milliliters. Which leaves us with how much for a stroke volume? 70. So we start out with 120. There was 50 left over in the ventricles. That means that we ejected 70 milliliters. So let's say we're in our fight or flight mode and epinephrine and norepinephrine were just released on the ventricles of the heart. So the heart is now contracting more forcefully, and now there's less blood left over in the ventricles because of that increase in contractility. So our starting volume is still the same. But let's say our ESV goes down because our contractility went up. Now we only have 30 milliliters per beat left over. What's our new stroke volume? 90. So does that make sense? If we increase the contractility and there's less left over, that means we have ejected more blood. So we have increased stroke volume.
We were just asked a question about this on the exam. If we provided those numbers, or do we have to remember
Remember the volumes? No, I would give you the volumes.
Oh,
Yeah. Huh? They do have to remember the average stroke volume, so you should remember the average. So these numbers here, the average, yes. But if I were to tell you, I would tell you, I wouldn't just say what is the new stroke volume with an increased contractility. I would give you the new volume. And those are the averages. I don't know if there's a question where they have to, definitely stroke volume. But I don't know if there's a question where they had to know the EDV and ESV values. You tell me when we're in lab and then I'll tell them. Okay, so questions about that. Questions about how contractility can increase stroke volume. Okay. So other extrinsic factors that can decrease ESV or increase contractility include an increase in thyroid hormone. So when you have an increase in thyroid hormone, what does that increase? What's the response of thyroid hormone? What was it? Metabolism. It's going to increase metabolism. So when it increases metabolism, that is increasing metabolism body-wide. So that's increasing the work of all of our cells, including the cardiac cells. So in this case, with an increase in thyroid hormone, the thyroid hormone can directly enter cardiomyocytes, which is just cardiac muscle cells, and alter or increase their activity. So thyroid hormone can make your cardiac cells work harder, so it increases contractility, which is going to decrease the amount of blood left over, or ESV, which increases your stroke volume. Another way to increase contractility, which is going to decrease ESV, is a heart medication called digitalis, sometimes called digoxin or lanoxin. Those are all heart medications. And how they increase contractility is they work by increasing intracellular calcium. So the more calcium you have available at any time, the harder the heart can work. Right? So the more calcium, the harder the contraction. Which is why I will talk about in a little bit that you can also take calcium channel blockers to slow down the heart as well. And then one last way to increase contractility is hypercalcemia. So if you're hypercalcemic, your blood has more calcium than normal. That means that more calcium can leak into your cardiac cells, which means that the cardiac cells can contract harder. Anytime there's more calcium available to the heart, it will contract harder. So in this case, more calcium can enter cardiac cells or cardiac muscle cells, which is going to increase heart rate and increase contractility. All of these three things, thyroid hormone, digitalis, hypercalcemia, they're all referred to as positive inotropic agents. Inotropic means that it can change the force of contraction. So an inotropic agent is just anything that can change the force of the contractions. So a positive inotropic agent is going to positively change. So it's going to increase the contraction. So what would we call something that would decrease the contractility of the heart? Negative inotropic agents. Any questions about this? Anybody still writing stuff down? Okay. So substances that decrease contractility, and again, we would call this a negative inotropic agent. Are calcium channel blockers. This is used if the heart is damaged or you have coronary ischemia and you want to decrease the overall effort of the heart. Okay? It can also be used to decrease blood pressure because remember, the more calcium that's available to the heart, the faster and harder that it works. So we can prescribe calcium channel blockers so that less calcium enters the cardiac muscle cells and they don't work as hard because you do not want a damaged heart overworking. Or a heart that's starved for oxygen. You don't want it working too hard. So any questions about that?
You said less calcium enters.
The heart cells, cardiac muscle cells. Okay, so we talked about preload, which is related to the amount of blood that we start off with that's going to be ejected. Now we have what's called afterload. So afterload is the pressure the ventricles must overcome to eject blood. Because remember we said that in order to eject blood and in order for the semilunar valves open, the pressure in here in the ventricles has to be greater than the pressure in the aorta and the pulmonary trunk. So the ventricles have to have a greater pressure than the vessel in front of it in order for those valves to open and for us to be able to eject blood. So if we end up having, so if we're somebody who has hypertension, who has high blood pressure, and there's high blood pressure in our aorta, then that means that the left ventricle has to overcome an even greater pressure in order to overcome that pressure in order to eject. Okay, so if our aorta has a high blood pressure, our ventricles have to contract more, build up more pressure in order to eject the blood, to overcome that pressure. Does that make sense? So if blood pressure is high in the aorta, then and the heart has to work harder, it's going to be able to eject less blood. It's not going to be able to eject as much blood as if you didn't have hypertension, right? Because it's going to take more time to build up enough pressure to eject the blood. Now you have less time to eject that blood. So if we have high blood pressure in the aorta, then blood ejection is reduced, so we have more left over. So what does that do to our stroke volume? Decreases it. We're going to be ejecting less blood. Because if we have to overcome a higher pressure, that takes more time to build up enough pressure in the ventricles, and we're not going to get as much ejection. So any questions about that? It's basically the amount of pressure that the ventricles have to exert in order to force those semilunar valves open. And if the aorta has too high of a pressure, it's going to have a harder time opening those valves. The leftover volume, the ESV, is going to increase, which decreases our stroke volume. So that's going to take a bit of review. I know there was a lot of acronyms, a lot of increases and decreases, a lot of relationships. So we do have a long weekend this weekend. Okay, so make sure you take as much time as possible. Don't wait until Monday, the day off. Study this weekend. I will say, as far as lecture goes, heart is probably the hardest part. Especially because we have 3 lectures on it, and you can get into a lot of detail in 3 lectures. As far as anatomy goes, probably the blood vessels will be hardest that we're going to get started on today. So don't waste this free weekend. I know everybody gets excited about a 3-day weekend. Don't waste it. Use it. Don't forget that I said that this next exam, which is now in 2.5 weeks, okay, is the hardest one of the semester. Do not take it lightly, okay? So make sure that you're studying as much as you possibly can, getting as close to those 20 hours a week as you possibly can, because don't let it surprise you, okay? I want you guys to make sure that you're prepared. Yeah?
Because there's 3 lectures, is it still going to be 5, is it going to be 5 questions?
It'll still be 5 questions. Usually if there's, if it's a big quiz, I'll put an extra question on there. I already did that last week, and I think the week before, so don't tell anyone, but I'll probably put an extra question on there for this quiz as well. So you'll have a quiz when you come back next Wednesday on Heart 1, 2, and 3. So study. And go to PAL. Okay, so regulation of heart rate. We talked about this a little bit last time. Our parasympathetic nervous system has what we call parasympathetic tone, which keeps our heart rate between 60 and 80. So our average heart rate is about 75 beats per minute, and that's due to the parasympathetic nervous system. It keeps what's called parasympathetic tone. So if the vagus nerve were severed, which remember it's our only cranial nerve that's able to control our visceral organs, but if the vagus nerve were severed, the heart, because it's autorhythmic and can work on its own, it'll naturally want to beat at about 100 beats per minute. But our parasympathetic nervous system keeps it down at our normal, about 75 beats per minute. And so as far as the sympathetic nervous system goes, we can prescribe beta blockers to interfere with the epinephrine and norepinephrine docking to prevent it from speeding up or working too hard. Because when our catecholamines, I'll say when catecholamines bind at those beta 1 adrenergic receptors, it causes, and this is specifically at the SA and AV node, because those are our pacemaker cells, it causes threshold to be reached more quickly. So essentially what's happening is that the SA node increases its firing, and we're reaching causes an increase in heart rate. So if we were to prescribe beta blockers, this is going to decrease contractility to, too many L's, that's way too many L's. So by prescribing beta blockers, it's going to decrease contractility because the epinephrine, norepinephrine won't be able to bind here, at least not as often. It's going to decrease heart rate because that norepinephrine and epinephrine won't be able to bind at the SA node and the AV node. But you should know that beta blockers only affect sympathetic control. So this is only going to be effective during times of fight or flight. So this is going to keep the heart from working too hard when someone gets too excited, or when somebody attempts to work out, or gets afraid or anxious, or whatever the fight or flight cause is. Okay? So beta blockers only work in times of fight or flight. Calcium blockers that we talked about before work all the time. Okay? Those are always working. Beta blockers only work in times of stress. So you can make a note, calcium blockers work all the time, because it doesn't matter what state you're in, whether you're resting or you're in time of stress or physical activity. The more calcium you have available, the harder your heart's going to work. So if you prescribe calcium blockers, it's going to decrease the effort of the heart all the time. Beta blockers only interfere with epinephrine and norepinephrine, so beta blockers only work during fight or flight mode. So any questions about that? Yeah.
Could you repeat why when the vagus nerve is severed down,
The heart speeds up. Okay, so the heart naturally wants to beat at 100 beats per minute. So that's because that's just the way that the heart works. Okay, it's autorhythmic, and its natural pacing wants to be at about 100 beats per minute. But we have control through our parasympathetic nervous system. It's called parasympathetic tone, that keeps our heart rate at a more manageable level at about 75 beats per minute. We wouldn't want our heart beating at 100 or more beats per minute all day long. That would make us real stressed out and anxious. Okay, so our parasympathetic nervous system keeps it down at 75 beats per minute. Yeah.
so if the vagus nerve was severed, it wouldn't be able to keep the parasympathetic tone? Is that what you're saying?
Yeah, the parasympathetic tone would be lost, and so the heart would beat at 100 beats per minute if the vagus nerve were severed. So there's going to be a question on one of your exams where asks you what happens if the vagus nerve was severed, and I'll have a bunch of different options. The option that you're going to pick is that it increases the heart rate by 25 beats per minute. And it's going to give you a bunch of other options that are not true. I don't remember off the top of my head what they are. Okay, any questions about that? Okay. So regulation of heart rate, our hormones, epinephrine and norepinephrine. So epinephrine and norepinephrine, they're considered hormones and they're considered neurotransmitters. They can do both. So they can travel through a synapse and they can travel through the blood. Okay? If you want to know, norepinephrine acts more as a neurotransmitter, so it acts in that way most often. Epinephrine acts more as a hormone most often. but they can both do both. So they can both act as both, but epinephrine acts as a hormone more often, norepinephrine acts as a neurotransmitter more often. But they are both. So we already know that epinephrine and norepinephrine can speed up the heart and can make it contract more forcefully. Thyroid hormone does that as well. It acts on the heart to increase metabolism. And heat. And the more hot cells are, the faster they work as well. But also, thyroid hormone enhances the effect of epinephrine and norepinephrine. What kind of hormonal interaction is that? If thyroid hormone enhances the effects of norepinephrine and epinephrine. Synergism. So this is why undiagnosed hyperthyroidism, and so if you're overproducing thyroid hormone, that can lead to premature heart failure because it's increasing the metabolism of the heart, and then especially in times of fight or flight, if you have more epinephrine, norepinephrine around and more thyroid hormone around, that's going to enhance those effects and your heart works even harder than it should, which can lead to heart failure. One thing I want you guys to get into the habit of doing when you study is looking for keywords that help you narrow down what the options are for answers. So if I'm asking you for a hormone interaction, it can only be antagonism, synergism, or permissiveness. If I'm asking you for the type of hormonal stimulus, it can only be hormonal, humoral, or neural. So look for keywords that tell you like what I'm asking for so that you can narrow down your options. Okay? Those are things you want to be highlighting in your notes and writing things down so that you can use a process of elimination. What exactly is she asking me for? Okay. Ion imbalance. This can also influence the work of the heart. So again, we said that if you have too much calcium, anytime you have an increase in the availability of calcium, increased calcium can increase heart rate and increase contractility. To a point. Okay, so it can increase heart rate and contractility, which can be okay. Contractility. But to a point. Okay, if you have way too much calcium, like in the case of hypercalcemia, this can disrupt function and can cause life-threatening arrhythmias. So you can definitely overdose on calcium and it can have really negative effects. On the other hand, if you're hypocalcemic and your heart doesn't have enough calcium available to keep up with the contraction and activity of the heart, this can depress the heart. And not make it sad, but just going to decrease its activity more than normal. Also, having too much or not enough potassium can cause heart irregulations, and that's called hyper and hypokalemia, okay, because potassium starts with a K, okay, so it's kalemia for potassium. So anytime you have differences in the levels of potassium that's available, it can alter electrical activity. Because remember, we need to have certain concentrations of potassium in and out of our cells in order to allow for the repolarization of cells. That's all important for the repolarization part of our action potentials. So if you have too much potassium in the blood, if you're hyperkalemic, this can lead to a heart block, or an MI. Because if you have too much potassium in the blood, you're not going to be able to have that efflux of potassium out of the cell to cause the repolarization, which makes you kind of stuck at the top of the action potential, which can cause a heart attack. Right? If you don't have enough potassium, if you're hypokalemic, then this can lead to other arrhythmias and a weak heartbeat. So your heart won't work as hard, which is a bad thing. So any questions about that? Yeah.
What do you mean by depressed in the heart?
It just slows it down. Slows it down and doesn't work as hard. Anybody still need these notes up? Okay. So last thing, other factors that affect the heart rate is age. One example is that a fetal heart rate is about double what our normal heart rate is. So a fetal heart rate is about 150 beats per minute. So age definitely has a factor. And small infants and small children will normally have higher heart rates than adults because their hearts are tiny, so they have to work a little bit faster to get that blood out. Gender is going to take an effect as well. What do we say about males' hearts? Are they larger or smaller than women's? Larger. So males, because they have a larger heart, okay, that's more muscular, males have, in general, a lower resting heart rate. So there was an activity in your lab last time talking about bradycardia in athletes. Okay? If you're an athlete and you do a lot of, especially endurance training, okay, a lot of cardio, your heart is going to be a lot stronger and a lot more muscular. So that means that the heart can work a lot less hard, doesn't have to work as hard to get the same amount of blood out. So it can pump less beats per minute and get the same ejection as somebody who's a non-athlete. Okay. So I told some of you guys that Michael Phelps had a crazy resting heart rate during his Olympic training. It was like 39 beats per minute. Something crazy low because his heart is just so strong that it doesn't have to work that hard. It can work at a lot slower rate and get the same cardiac output. Exercise is also going to affect your heart rate. The harder you work, the faster your heart is going to be beating. Your body temperature as well. If you have an increase in temperature in any cells, increased temperature means increased metabolism. So I don't know if you've noticed this, but many times if you have a high fever, your heart rate will increase as well because your entire body is hot. Your core temperature is hot. And so your cells start working faster, including your heart cells, and so your heart rate increases. Which is why when you get really, really high fevers, it can be dangerous. And also why it can be dangerous is if your temperature is too high, if you remember about proteins and enzymes, they start to denature at certain temperatures. So then you can start losing functions if your fever is too high. So that's why you have an increased heart rate with fever. Any questions? That's it. We're done with heart. But you do have a post-lecture assignment. It's PLA number 5. It's all about clinical heart terms. Looks like this. It will be talking about bradycardia, tachycardia, and congestive heart failure. So after you do this, then you'll be able to answer today's case study.